Welcome to this sixth and final seminar in our series, Modern Methods in Social Policy and Intervention Research. My name is Mark Fransham. I am a Senior Research Officer and Departmental Lecturer here at the Department of Social Policy and Intervention. I'm extremely pleased today to be welcoming Dr. Kate Guastaferro from Penn State University. Her talk is going to be titled, as you can see there, An Introduction to the Multiphase Optimization Strategy, Opportunities for Intervention Science. So very much looking forward to hear Kate speak today. Kate is an Assistant Research Professor in the Centre for Healthy Children and an affiliate of the Child Maltreatment Solutions Network and the Edna Bennett Pierce Prevention Research Centre at Pennsylvania State University. Kate's focus during her time at Penn State has been predominantly on the prevention of child sexual abuse. Kate has led the development of a parent-focused child sexual abuse prevention module designed to be added to existing evidence-based programs and collaborates on the implementation and evaluation of a statewide child sexual abuse prevention strategy. Kate is also interested in innovative methods for intervention development, optimization, and evaluation, and she is an expert in the multi-phase optimization strategy that she's going to talk to us about this afternoon. Kate's vision is to integrate her substantive and methodological interests to develop, optimize, evaluate, and disseminate child maltreatment prevention programs that are effective, efficient, economical, and scalable. So Kate, thank you ever so much for joining us this afternoon. Very much appreciate you being here, and I will hand over the virtual floor to you.
Thank you, Mark. I'm very excited to be here, and thank you all for your interest and participation and hopefully a good discussion later today. So a couple quick things just to say. My goal today is to just inspire maybe a different way of thinking about intervention development. There's no possible way that I could cover all that is most in this time. We can barely do it in our 5-day trainings. So you might have some unanswered questions at the end of this, but I'm hoping that I will point you to some resources. And then the other thing that I'll just point out on this screen is my Twitter handle. I would very much encourage and welcome some new followers. I like to share resources about most through that. All right, so let's get started. The first and most important thing to acknowledge is that most is not mine. I'm very fortunate to have been mentored and trained by Dr. Linda Collins, who is the developer of most. And so I'm just acknowledging that here. So let's start by talking about the traditional way that we might develop behavioral, biobehavioral, biomedical, social structural interventions. This is the way it's been done for decades, right? We identify components that we think are important to affecting our outcome of interest. Those components might be identified through the literature, through our prior work, through clinical knowledge, but these are the things that we're like, yes, this is what we must include. So we pick them out and we package them together into this proverbial black box. This is our intervention. And then we test that in an RCT. And any number of behavioral interventions have been developed in this way. And there's nothing wrong with evaluating an intervention via an RCT or packaging stuff this way. But there are some unanswered questions if we adopt this traditional approach. So by evaluating an intervention in an RCT, we cannot identify the contribution of individual components to our outcome. We don't know whether the inclusion of one component has an impact on the effect of another. So if there's a positive or negative kind of reaction or interaction between those components. We have no idea if a component is worth its cost. So there might be some very resource intensive components. So in my world, maybe it's a type of therapy. Does that produce enough of an effect on our outcome to offset the cost of implementing it? We don't know. We also have, this is my favorite point, we have no idea if we need all of those components that we identified. So you might have heard people talk about the kitchen sink approach, where we just chuck everything that makes sense into an intervention. Well, we have no idea if we need all of those things. And to that end, we don't know what to do next, how to make the intervention more effective, efficient, or scalable. An RCT is also incredibly resource intensive, whether it's about money or time it takes to execute an RCT. And all of that, expenditure produces quite limited information. Also, by definition, an RCT is conducted in a highly controlled environment. So you really don't know at the end of that very expensive time if what you've done is going to work in the real world, or if it's possible to disseminate on a wide scale. And, we've all been there, and I'm, admitting this myself. You get to the end of an RCT and you don't have a positive effect, right? So what happens? What do you do next? With the RCT, you don't have the empirical information to inform those next steps. So one solution that I'm offering to you today, to those, kind of drawbacks to this approach, is the multi-phase optimization strategy, or MOST. So MOST is an engineering-inspired framework for optimizing multi-component behavioral, biobehavioral, biomedical, or social structural interventions. Probably just going to say behavioral interventions for the sake of efficiency here. But I want to emphasize here that this is a framework. It is not a method or an off-the-shelf procedure. And then I will highlight here, you don't do a talk to not share your own papers. So this is a perspective that Linda and I published in 2019, kind of offering some of the thoughts that I will go through today. All right, so let's break down what MOST is a bit more. So I'm highlighting here that this is about multi-component interventions. For me, a component is any aspect of an intervention that could be separated out for study. So that might be the content bits of an intervention. So if it's motivational interviewing or some type of behavioral therapy, those are content-oriented components. A component might also be something that's targeted at promoting compliance or adherence or engagement. So maybe it's like a text message reminder or homework to practice the skills in between sessions. Finally, a component could also be something aimed at improving fidelity. So maybe that's a different type of training for your provider, or coaching and monitoring of that. So a component, anything that could be separated out for study. All right, back to our definition. When I say optimizing, I mean something very specific. It is the process of identifying an intervention that provides the best expected outcome obtainable within key constraints that are imposed by the needs for affordability, scalability, or efficiency. So you can see kind of in this definition that we're bringing in aspects of implementation science. A constraint is anything that interferes with implementation. So is it cost? How much it costs to actually deliver this to a person? Is it the provider time to deliver it, or the participant burden? All of those things might be considered constraints. So the figure that I showed at the beginning about how we develop an intervention, this is similar, but there are some key differences, right? We are still identifying components in the same way through theory, literature, studies, clinical guidance, but we're going to empirically examine those components before we package them together. So the insertion here of the triangle figure, we are going to empirically optimize our intervention, which means conducting an efficient experiment to understand the individual contribution of each component to our outcome, as well as the way in which they interact with each other. Based on that empirical study, we then are going to identify our optimized intervention, which is comprised of only the components that meet our a priori specified objective, which I'll return to. The box is no longer black, right? Because we know how those components are working towards our outcome. And then the RCT comes back. The difference here is that by the time we get to the RCT, we know what's working and we have a clear, more information about what we might do moving forward. So a behavioral scientist, intervention scientist who is using MOST is after 4 qualities or desiderata of their multi-component intervention. Of course, we want an intervention that's effective, but we also want an intervention that is affordable, which means that it's effective without exceeding our budgetary constraints. If you design an intervention that costs $5,000 per person to deliver, I mean, at least in the US, like that's definitely not going to be a choice or implemented, right? And just a small note, because I do know that there are some names on this call who have experience with MOST before. This desiderata used to be called economy, but we're switching our language and now it's called affordability. All right, so we're after effectiveness and affordability. We're also after scalability, which means the extent to which the intervention can be implemented widely with fidelity quickly, like following the experiment. And then finally, efficiency. So that's the extent to which the intervention avoids wasting resources. You'll notice what we're after here is an intervention with ease. This is a strategic balance of the desiderata. So you achieve ease by balancing effectiveness against affordability, scalability, and efficiency. So as you move through the multi-phase optimization strategy framework, you are building not only the effectiveness, but maximizing affordability, scalability, and efficiency. So this is what MOST kind of looks like in the how-to, if you will. I'm going to go through each of these phases in detail, but like brief detail next, but I just kind of want to orient you to the figure first. There are 3 phases of MOST: preparation, optimization, and evaluation. So in the preparation phase, the goal here is to lay the groundwork for optimization. So this is like not really all that different from what we might do in our traditional treatment package approach to intervention development. You're creating a conceptual model, identifying candidate components, doing pilot work, and one thing that is different in the MOST framework, you're identifying an optimization objective. So we're going to go through those. So this is an extremely generic outline of a conceptual model. On the left, I'm specifying each of my intervention components and then specifying which mediator those components target, and then how those mediators ultimately get to my outcome of interest. So this is fairly straightforward. Between the mediators and the outcome, you could create something far more intricate. That's where theory and the causal process of changing behaviors is depicted, which I will say again in a moment when I get to my animation. There it is. So that part in this circle is depicting the process that you are changing. When I read a conceptual model and when I develop one, I often work from left to right, so the component to the outcome, but I think it is equally as important to go the reverse as well to make sure that that makes sense. So here's a hypothetical example of a conceptual model that we did in my field of study. So this is a hypothetical intervention trying to reduce PTSD symptom severity among children who've experienced maltreatment. So again, on the left, you see I have my 5 candidate intervention components. I'm specifying which mediator each component targets, and then how it gets to the outcome of interest. And so I would read it left to right to say that my component working on relaxation training is targeting stress biology impairment. And when I improve the stress biology response, then I am reducing the PTSD symptom severity. But just as important to go backwards, right? So PTSD symptom severity is affected by these 5 different mediators. So I just to demonstrate that you got to go both ways. So another objective of the preparation phase is to identify and solidify your optimization objective. This expresses kind of your goal that you want to achieve in this process of optimization, and it's yours. So there is no correct optimization objective, and the intervention that I develop would be perhaps quite different from one that you might yourself. So some examples. Perhaps the most commonly used one is what we refer to as the all active components optimization objective. This means that you are after the most effective intervention, irrespective of cost. So you're just including the components that have a positive effect on your outcome. So like maybe trimming the fat of the components that don't contribute to that outcome. Another example might be time. So if you know that there's an upper limit on the amount of time a provider has with a particular participant, that could come into play here. So for example, you want to identify the most effective intervention that can be implemented in 45 minutes or less. Along the same notion here, maybe cost comes into play, and you know that you can only spend $500 per person. So those things might come into play as your optimization objective. But I want to emphasize that there is nothing wrong with the all active components optimization objective. This is doing better than we normally would in the traditional intervention development approach, right? Because you're losing the components that don't contribute to your outcome. And I think it's a great place to start. Okay, I'm off my soapbox on that. Also within the preparation phase is pilot work. For us, this is hypothesis generating rather than hypothesis testing. And that usually means it's not powered. So any experimental design is appropriate here, but for some examples, you could do a pre-post test, you could use single case design. You might also use data from a previous RCT to kind of inform the preparation phase. All of that is appropriate here. The other thing that is important to note, especially for perhaps early career investigators, is that you could do a pilot of an optimization trial. So I know that I haven't explained what that is yet. So I'll return to this in a moment, but it could be appropriate to pilot the factorial experimental design, especially when you're early career, to demonstrate that I, Kate, can manage X number of experimental conditions, that I can recruit this number of participants and retain them. So that all falls within the preparation phase. The second phase is the optimization phase. And remember, this is where most differs from the traditional approach. In the optimization phase, we are building that optimized intervention via an optimization trial, which we're going to get into right now. So the optimization trial could be any experimental design that works for you and answers these 3 points. It should be matched to your research question, as well as the type of intervention that you are developing. So I will return to that in just 1 second. And also, the selection of the experimental design should adhere to the resource management principle. So this is part of MOST, that's this engineering inspired bit. This says that if you are trying to design, let's say, a 32 arm RCT, that you don't have the resources for that, right? Like nobody does. And so that would not be the appropriate experimental design to select for an optimization trial. So as I said, the selection of your experimental design for the optimization trial should be matched to your research question as well as the type of intervention. So on the left here, you see types of interventions. I thought that I put in some graphics, and I didn't. Oh well. A fixed intervention at the top is where everybody gets the same kind of level, the same intervention. As you move down that column, you get to an adaptive intervention where my response to some particular thresholds dictates whether a change in the intervention that I get. So that's adaptive. So for example, if I have an adaptive intervention, the appropriate experimental design for me, one of them might be the SMART. So the sequential multiple assignment randomized trial. Well, here's the animation, sorry. An adaptive intervention, as I said, is one where the levels of the intervention are individualized. And this is appropriate when there's high heterogeneity in response, in need for or response to a particular intervention. Maybe you've got some changing or ebbing and flowing kind of course of disorders. It's also appropriate if the intervention is particularly burdensome or costly, because if I respond with this level, then you shouldn't up the intervention that I get, right? But if I don't respond, then I might need a little bit more. And so that's why you might choose an adaptive intervention. The SMART, I'm not going to get into a ton of these details, but I just like to kind of whet your appetite, if you will. So this is a multi-stage randomized trial where there's multiple points of randomization that are dictated by decision points of scientific interest. So you kind of have to know quite a lot in order to identify those points where you need to re-randomize. Yeah. So the other end of this, the fixed intervention where everybody gets the same kind of level, the appropriate experimental design is a factorial or fractional factorial experiment. So this is appropriate when you don't know which components produce desirable effects, when you don't know which components could be reduced or removed without sacrificing your outcome, your effect. It could also be appropriate when you have cost or other constraints to consider in what's the word, in the same time as your outcome. And when you need a treatment package, the intervention that is suitable for the most number of people, like for the average group. So that's when the factorial experiment is appropriate. Here's what this looks like. This is a factorial experiment with 4 factors. And just a note about language. So I, in the preparation phase, would refer to these as components of my intervention. But now in the optimization phase, when we're talking about experimental design, they're called factors. They mean the same thing. It's statistics. We like to use the same word, different words for the same thing. Anyway, so this depicts 4 factors. Each factor has 2 levels. So in the diagram, it's written as no or yes, which would indicate whether they get it or they don't. So on or off, but it might also be low or high intensity, low or high dose. You can specify those levels as makes sense to you. And it is possible to have more than 2 factors, but it has very serious implications for your sample size and power. So we try to recommend that you just choose 2 levels. Okay, and then some notes about the notation of a factorial experiment. So what you see depicted in the graphic is a 2 to the 4th factorial experiment, which yields 16 experimental conditions. So the 2 in this numbering here, reflects the number of levels, 4 reflects the number of factors. So a 2 to the 5th factorial experiment would yield 32 experimental conditions. So this is my favorite slide of the whole presentation. This is like the magical bit about factorial experiments. So recall my example of my hypothetical PTSD reduction intervention. So the point of this slide is to show you that the factorial experiment is actually quite efficient when you talk about the number of subjects you need. So in that hypothetical example, I had 5 candidate components. If I chose to do individual experiments for each of those components, I would have 10 experimental conditions, right? And in order to maintain power over 0.8 and to detect an effect of 0.3, I would need 1,760 participants, and I couldn't estimate any of the interactions between those conditions. That's a lot of people in my world. Say I chose a comparative treatment design where I have 1 control group and 5 experimental conditions for a total of 6. Maintaining the same power and effect size estimate, the number comes down. So I need 1,056 participants, and I still cannot estimate those interactions. Well, if I chose a factorial experiment, yes, I would have 32 experimental conditions, but to be fully powered, I only need 352 participants. And if you do that math, that is 11 participants per condition. I can't see your faces, but I know that you're just like, whoa. And the other cool part about this is that you can estimate, you're fully powered, and you can estimate all of the interactions between those 5 factors. So 11 per condition sounds like, uh-oh, I'm going to be in trouble, but you're not. So powering the factorial trial could seem scary. It's not. To do this, you need to identify the effect size for each of your components, and then select the smallest of those effect sizes, right? Now, if you are unable to identify the effect size for each of those components, say because you are dismantling an existing intervention and it's never been tested in those parts before, you would consider maybe what's the smallest effect size that would be palatable to the field. So if I'm unable to estimate the effect of each of my components, the smallest effect that I would feel good about including might be like a Cohen's d of 0.2, and that's fine. We also recommend that, especially when resources are tight, you consider increasing your alpha from 0.05 to 0.10. The reason behind this, and you can cite Linda's book, which is super awesome when you're writing a grant proposal, your purpose of the optimization trial is to make decisions about what components to include, and therefore the alpha of 0.10 is appropriate. You will then go to the RCT where you can bring back that alpha of 0.05. The other things that you can take into account with a optimization trial, a factorial optimization trial, is that you can handle multi-level data. So if you have clusters, whether it's schools or school districts or clinics or therapy groups, all of that, kind of group level stuff can be taken into account. I will say though that oftentimes there are not enough groups to match what you need to be powered. And so sometimes you got to rethink the components in order to make it feasible. You can answer more questions about that later. So here is an example. Let's say we've got to the end of our optimization trial and we're ready to make some decisions about what our optimized intervention is going to be. So this is a example of a 4-component smoking cessation intervention. So we've got 4 possible factors or our components: pre-quit nicotine, pre-quit counseling, in-person counseling, and telephone counseling. This is showing you our 16 experimental conditions, which has all of the possible combinations of these 4 components. So we get to the end of our optimization trial, and I'm not talking about interactions here. So we have this, very familiar equation, and we plug in our results. And let's say we end up with this. Our outcome here of interest is the predicted days smoke-free. So you see for each one of the conditions, the estimated number of days smoke-free that I get for that combination. So the greatest number of days smoke-free is, you see with experimental condition 16, where all 4 components, or all four factors are turned on. I get 26 days. Cool. But now let's suppose, this is definitely more an example for the US, but bear with me. Let's just suppose that our insurers are only willing to pay $500 per patient. So this is now our optimization objective, where we want to identify the intervention that produces the best expected outcome on days smoke-free for no more than $500 per person. And we know the cost of implementing each one of those components. So that gets plugged in, whether it's on or off, right? And that estimates the number of the amount per condition. So that now is added to this, and you see that on the very far right column, our expected cost of each one of these conditions. And so those that are highlighted in red are over $500. They're out. You can't look at them. Notice it's experimental condition 16, which gave me the greatest number of days. For $500, I can get 18 days smoke-free. Okay. But look, here I can get 20 days smoke-free for $475. So this is where, like, I'm sold 100% on most the first time I heard this, because now I'm getting, if I had just said $500, we would have only selected 18 days smoke-free. But because of the way that this experiment was set up, I actually know that I can get more days for less money. And then I think the other thing that's useful for this is these data, the outcomes, become available for people in other settings to make choices about themselves. And that increases the scalability of our findings. All right, one more example. So this is the opt-in trial, and the investigators were Bonnie Spring and Linda Collins. The opt-in trial sought to design an effective and efficient weight loss intervention comprised of only those that produced an effective outcome. And they wanted to know what components worked best, and then which met the optimization objective of $500. So I'm not going into all of the details here, but they had a 2 to the 5 factorial experiment. You see the experimental conditions listed out there. Their trial enrolled 562 participants, predominantly female, with a BMI of over 32. All of the participants received a core intervention, and this is possible where everybody gets some type of basic part that you are not able to estimate the effect of because you're not experimentally manipulating this, but that's an option. It's appropriate in certain circumstances. So this was like a basic psychoeducation piece that then the other factors were added onto. So this is the results that are presented in the spring 2020 paper, which I'm happy to share if you're interested. This is showing the 4 combinations that produced the greatest weight loss and the cost of each. So they wanted to have something under $500. And I think it's just worth pointing out that the last row experimental condition 17, all of the factors were off except for the calls. And that was $324 and still produced a fairly high weight loss. And so this, again, kind of just shows you all of the available data you get that can inform choices you make. So some summary points here. Through using the optimization trial, they were able to eliminate components that didn't contribute to the outcome, thereby increasing the efficiency as well as the affordability of the intervention. And now that opt-in, that intervention is being evaluated in an RCT. So it's moved into the evaluation phase, which is where we are. So at the end of the optimization phase, you've identified your optimized intervention. And if you think that it is expected to be sufficiently effective, then the course of action is to move on to the evaluation phase. However, if you get to the end of the optimization phase and you don't think what you've done is going to be effective, then adhering to the resource management principle, you would return to the preparation phase and tinker with your conceptual model, your components, and go through the process again. But let's be positive here. Let's say that we do think our intervention is going to be effective and we go into the evaluation phase. So there's a difference here in our goals. In the evaluation phase, we are comparing the optimized intervention package to a suitable control. And the RCT is a good way to do this. Whereas in the optimization phase, our goal is to examine the individual components and the way that they interact. An RCT is not the right experimental design for this because all of the components are confounded. And so the optimization phase uses other experimental designs. I do want to just say, though, that it doesn't have to be an RCT. The whole point about matching your design to your question comes into play. And so if you're interested, we just published a paper, which I'm going to talk about in a bit, but we didn't use an RCT in our evaluation phase. We used a 2x2 factorial. So it doesn't have to be an RCT. That's like just a little spoiler alert for what's coming. Okay, so one of the principles that kind of guides the most framework is the continual optimization principle. And this holds that even a optimized intervention that has made it through the evaluation phase could be further optimized. There are always going to be new scientific findings, new constraints, different resources available that might change the optimized intervention you find. You can always make it better. And so to me, I think this is really exciting because we are always trying to improve the interventions that we are disseminating to the people who need them. For other folks, they take this more like, oh, I'm never done. But I would just encourage us to think like, this is a way for us to achieve public health impact. All right, and then the other principle I've already kind of alluded to is the resource management principle, which just means to choose the design, to choose everything that kind of aligns with the resources you have available or that you can reasonably obtain, like through a grant. All right, so some examples of work. And I'm highlighting these because it gives you a sense of like possible publication opportunities from MOST and different applications of it. Because the most exciting thing to me is that no application of MOST is the same, which makes it difficult, I understand, to learn, but I think is really exciting. So the first paper I'm highlighting is a paper written by a group of us who are applying MOST to the field of palliative care. And so this paper is really like a introduction about what MOST could do for this particular area. I think that this type of paper is really good if you're trying to crack into a new area where MOST has yet to be applied. So there's that. this is a paper on it's called It Matters, and it's a digital health intervention for first-year college students. And the goal of that intervention is to prevent sexually transmitted infections via reducing risky sexual behaviors and excessive alcohol use. And so the reason I put this one is that it's an iterative process. Because it was a digital intervention and we had a new sample every fall of first-year college students, we were able to do 2 optimization trials before we got to the evaluation phase. So that iterative process is really exciting, and I think possible in a lot of different ways, but especially in a digital health setting. And then I spoiler alerted this one already, but this is the evaluation of the It Matters intervention. So we coined the term a hybrid evaluation optimization trial. So we took our optimized intervention from the prior studies and tested it in a 2x2 factorial. So I was still able to estimate the effect of the optimized intervention to a control, but could add on another component in this design that could inform the next iteration of this. And so the point here is that it doesn't have to be an RCT. Use the resources you have available to answer the question. And then finally, wanted to highlight here, this is a project by Sarah Beth Broder-Fingert and Emily Feinberg. They are, to our knowledge, one of the first to use MOST in an implementation science project. So their optimization is about implementation and those factors as opposed to the content of an intervention. And so this protocol was published in Trials in 2019, and I think offers some interesting ways to think about other applications of MOST. And as an aside, something that I've been thinking quite a bit about is, okay, so there are a number of existing interventions in my field in particular. So maybe I don't need to create a brand new one, but maybe I could make the ones that exist better by using MOST. And so if the developer of an intervention is perhaps not willing to let go and say that you could cut out pieces of an intervention, well, maybe there's a way to improve it by looking at the implementation or the fidelity factors of that intervention. So just some thoughts. Okay, and some concluding kind of considerations to think about if you are considering using MOST. First of all, what type of intervention are you designing? Is it a fixed intervention or an adaptive intervention? I cannot tell you the number of people who contact us and they're like, I'm going to use a SMART. And that's cool, but your intervention doesn't work for a SMART. And so you need to match the design with your type of intervention. I already kind of alluded to this, but it is possible to take into account clustering with the optimization trial. And then this is a big one that I get from colleagues in the UK and across Europe. All of the examples that I've given you and shared with you today are about one outcome at the end of the intervention. We are actively working on a way to handle multiple outcomes using MOST. And so Linda, her graduate student, Jillian Strayhorn, and Dave Van Ness, who's faculty at Penn State, are working on applying Bayesian and multi-decision criteria analysis to MOST to be able to put forth some kind of best practices on how to handle multiple outcomes. So that's a teaser for the future. The other question that often happens is how to get this work funded. The Cliff Notes is that there is no one way to do this, and it works differently for your type of intervention, your field, your level of career. I did just do a webinar for the Society of Behavioral Medicine that talked about some funding opportunities. So if this is an area that you're interested in learning more, I would point you to that. But you can get this work funded. There's more than 100 projects in the US funded by the NIH. And so I think, could be hard, but don't let that stop you. And then, like I said, I do really welcome you guys to engage with me in any number of ways. This is my Twitter, as well as the, so it's the OBSIG, the Optimization of Behavioral and Biobehavioral Interventions Special Interest Group from the Society of Behavioral Medicine. And myself, as well as this other page, this is where we're really putting out like resources and training materials. So there's that. And then the textbook, if you will, foremost, is the book on the top. So this is Linda's authored book. It came out in 2018. This is where you can cite the alpha of 0.10 versus 0.05. This book follows the same structure as our multi-day training, and this is what you need in order to be able to do this. The second book is the Advanced Topics book, where you get a little bit more into the weeds, if you will. So that's information about how to handle moderators or mediation or adaptive interventions. And so these are the two resources that I would point you to. The other thing is that they should be available for free via Springer link. So Linda always tells people to not buy her book, which makes me chuckle. So anyway, that should be a way to, if you have trouble accessing those, please let me know. And then again, please feel free to contact me if you want to use most. I love to talk about it and would connect you with other people as well. So that's it for me.